of the American Association of Suicidology's Impacted Family and Friends Committee. And Trace, you want to introduce yourself?
Hi, everyone. My name is Tracy Medeiros. I'm a suicide attempt survivor. I'm also Anne-Marie's right hand and left, and eyesight too as well. So I do all kinds of stuff.
Melissa.
Hello, I'm Melissa Brown. I'm a suicidologist. I currently work as a behavioral scientist at the Center for Disease Control and the National Center for Injury Prevention and Control. And I work 100% on suicide prevention, although I worked on suicide before that.
Cool. Okay, so Trace, you're going to monitor the chat.
Yes, ma'am, I am.
Let us know if there are any questions, all right?
Yes, ma'am.
Okay, we'll talk to you soon. So, good evening, everyone. We have for me, a very personal and a fascinating topic, and that is suicide as a public health approach. And you can use whatever word and definition you have. And I'm just going to take a few minutes before we turn over to Melissa, because she's got some really cool stuff. And Melissa, I have to tell you that when I saw the post come in to the APA listserv, and you raised the bar about public health, here's the beginning of my rant, okay? I expected that you would be inundated with feedback and comments. And my count, it doesn't mean that was everybody who didn't back channel you, but my count was maybe a dozen tops responded to that. And so everyone, my background started with public health more than 30 years ago. Some of you know that I was a battered woman, and domestic violence was the beginning of my term of lived experience. And when I came out of that violence, I got my feet on the ground and my head cleared a bit, and I healed a little bit more. I was blessed. I had some really, really awesome people wrap their arms around me, kind of like the cavalry, to just hold me in. Because at that point in 1982, 1983, there were 2 domestic violence shelters in the state of Massachusetts, and you couldn't find them if your life depended on them, and my life depended on it. So as I started to heal, I got very involved in public participation and civic engagement. I became an activist and an advocate, because it was just so frustrating to me that there were no resources. I could not find any help anywhere. And that led to speaking on domestic violence at conferences and workshops and working in the field for a bit. At the same time, along with that, I was also working. I had been asked to come on board with an outpatient counseling agency for substance abuse, for alcohol and drug addiction, civilian outpatient place that was located on the U.S. Coast Guard base in Boston. And what happened is that in the beginning, when I got involved with domestic violence and teen dating violence, that was just in the early 80s, was just barely making the surface, is we were grassroots, feet on the street, boots on the ground, public health. Because the approach was, you have to wrap everybody around this. It isn't about one entity or another. It was everybody. We didn't have much money. We got a lot of work done. We reached out and helped a lot of people. Shelters started to pop up. And then the bubble just really broadened and broadened. And all of a sudden, there was state funding, and there was federal, violence against women happened in the federal level and at the state level. And again, we were still talking about the whole community being involved in this. And then something happened. Because up until that point, the whole attitude towards domestic violence was blame the victim. And that changed. And one of the most important pieces, if you've ever had a chance to read it, or never had a chance to read it, was Ann Jones's book, Next Time She'll Be Dead. And that was like my story. And I realized how close it was. But then things changed. Everything started to get centralized. You couldn't talk to people in the next community or in Central Mass or Western Mass unless you went through an organization called the Jane Doe Society. Everything started to funnel that way. People decided that must be the better way to do it. Well, it wasn't. and it didn't work well. We never got any more funding down at feet on the street level. Everything had to go through a process. Grants didn't even have anything to do with what you were going to do on the street. The language in the grants was just way out in left field, no game in the ballpark. And it was incredibly frustrating. And I had so hoped that 35 years later, we would not still be talking about the same cultural violence that we have. We lost that public health concept of a complete wraparound, a complete holistic picture about violence. At the same time, I was working in an outpatient counseling agency on the U.S. Coast Guard base, and we were dealing with substance abuse. We were dealing with people who were alcoholic and getting into treatment, and we were dealing with another population who identified as drug addicts. They were very separate at that time. And we were way outside the box. We were doing tremendous amount of really great work with very little money, but we did have a line item actually in the federal budget to be on the base like that. And then somewhere around, I want to say 1992, there was a change in the process. And all of a sudden, of course, we started with a just say no. That didn't work out so well either. Bart Andrews, I hope you're listening to me. I feel like I'm taking a page right out of your book to just rant about the non-public health approach to what are such an important public health issue. And so all of a sudden, we could not get people into detoxes or treatment centers unless they had a psychiatric diagnosis. Now, for those of you who may have are old enough to have worked back in the field of substance abuse at that time, you know that you were lucky if you didn't get a chair thrown at you, suggesting that they had to say they had some kind of mental illness, because that is not the process of healing and recovery that was going on at that particular time. And at that point, I stepped out of the game. I said, you know, I'm not playing. I'm not, it didn't feel right. It still doesn't feel right. What was needed was a complete comprehensive public health approach to recovery. And I stepped away and I went on to, I spent the next 12 years as a vocational teacher. So now that brings me to where we are with suicide and as a public health issue. One of the things, I do a lot of training and a lot of education in community. I cover 500,000 people, 20 cities and towns in Bristol County. And over and over and over and over again, I will hear someone say, when we lose a child in particular to suicide, all of a sudden city officials stand up and parents jump up and other community members jump up, city council members and leaders, and they say, well, what are the schools doing? And, you know, I come right back in their face and say, excuse me? I said, I don't know about you, but I always thought that people who got master's degrees in education was because they were going to teach us things. They were going to educate us. I don't believe they have a license to practice psychology, psychiatry, behavioral health. So before we yell and scream and holler about, well, what are the schools doing? My response and my knee-jerk kickback continues to be, what is the community doing? What are you all doing? Why don't we have tables where, and we had coalitions at one point that had the faith-based community, education community, the city government or town selectmen community, law enforcement, everybody that should be at a table would be there, and we would take a very holistic approach to that. And then someone decided it was a good idea to build silos, and that everybody has to stay locked up in those little silos, and you don't talk to each other anymore, and you certainly don't interact and collaborate anymore. So with that said, that's my take on where we've gone wrong. And I'm going to wrap up with this. In 2015, Tracy and I were out in Colorado at the Bridging the Divide Summit in Denver. And I want to say it's Lanny Berman. He'll correct me. He'll correct me if I'm wrong. He was one of the wrap-up final speakers, and he stood after his talk and he said, "What we need is an army. We need an army to address suicide." And I sort of like raised my hand in the crowd, didn't raise it up so anybody could see it, and said, "I know where you can get one." And what I was talking about was the impacted family, because we are the personification of public health approach. Over the last couple of years, either on the Zero Suicide listserv or on the even on the suicidology listserv, I've seen people like John Draper and other leaders in the field, especially in the public light, say, we need an army. And at this point, I raised my hand up and said, excuse me, we have one. It's called Impacted Family. By numbers, by the very nature of our numbers, if you don't understand the definition of impacted family, I guarantee that almost every single person listening to this and on the chat is an impacted family member. Because all it means is that you have been emotionally impacted and sometimes traumatized by the suicidal experience in crisis of someone you love. It could be a child, it could be a sibling, it could be your closest friend who continues to have chronic suicidal thinking. Some people make the mistake that they think it's all about loss survivors. No, it's not. We have many loss survivors at our table. I am a loss survivor. But my reason at the table is because I'm an impacted family member. And we have millions. We probably have more people who can fit under that blanket than can fit under all of the others combined. But none of this is going to work. And Melissa's about to tell you all about this new movement moving forward for public health. None of it will work if it is not informed by lived experience. We have pushed aside attempt survivors. We have given some voice to loss survivors, but so many attempt survivors and loss survivors cross the lines. So many people have an identification in both cases. And now as they move into life, they are now the impacted family because now they're concerned about their own loved ones who may be in crisis. That's why I'm saying that we have this army that can help, but we need to pull people out of the shadows. And what's holding it back is the constant prejudice, discrimination, and judgment the minute you say mental health, mental wellness. We don't treat people in public health that way. I had cancer. No one gave me a funny look. I've had skull fractures. I've had concussions. I had a brain aneurysm. And no one has ever said, oh, well, you have a mental health illness. No, I don't. Those are all public health issues. And until we bring a whole crew of lived experience people who can help inform the discussion, and we take a public health approach, I'm not sure. And I know there are going to be people who are going to push back. I don't think we have a solution for suicide unless we step into the public health community. And that's why I saw Melissa's post and I said, I need to talk to that woman. Melissa, I'm going to step back now that I've ranted. I'm going to step back and the table is yours.
Thank you, Anne-Marie. Can you hear me? Oh, I see my
Yeah, I can hear you fine.
Great. Okay, well, first of all, thank you very much for that. As both an attempt survivor and a loss survivor, I've had multiple family members who have died by suicide, and it was extremely impactful on my life. And I was very, very fortunate that when I was struggling to find a new direction to take my career, I ran into some wonderful people, specifically Julie Searle and Linda Moore, and they really helped a lot in finding a way to take this maelstrom of thoughts and emotions and do good with it. And so that's where I am today. So to start with, yes, I do work at CDC, but anything that I say here is my own words, my own discussion. It does not represent them. I am just fortunate enough to be able to have a job where I can work on my passion 24 hours a day, basically. So that being said, I want to start with just a few just general things about what public health and the public health approach, how it pairs with suicidology, why this is important, and just some basic background so that if anyone is unfamiliar with what we call the public health approach, you know what we're talking about. So to begin with, it's important to realize that this is not a new concept by any stretch of the imagination. So CDC has published quite a bit on the public health approach, and not just the public health approach in general, but also the public health approach addressing specific issues. There is, in fact, a public health approach to suicide prevention. There's a public health approach to violence prevention, dating violence, sexual violence, you name it, there is a specific public health approach tailored to that. In addition, the World Health Organization has published in 2012, I believe it was, Public Health Action for the Prevention of Suicide. So some of you may or may not be familiar with that. ASTO and CDC have applying the public health approach to suicide prevention, and SPRC has information as well on the public health approach specifically for suicide prevention. So all of that just to say, this is a well-recognized concept that we need to apply the public health approach when it comes to suicide and any type of violence or injury, that it is effective, it will be useful, and is useful where it's already being applied. So to begin with, if you're not already familiar with the socio-ecological model, I wanted to just mention that briefly, because this is where some of the disconnect comes between public health and a lot of clinical work. So the socio-ecological model has 4 levels. The individual level, which is where a lot of clinical work takes place. And then the second is the relationship level. And again, we have clinical work that takes place there also. And then we have levels 3 and 4, which are community and society. The concept there is that no one lives in a vacuum. You know, no matter where you are in this, you are an individual, but you also have relationships with others. You live in a community of some sort, and you are a part of society. So by definition, we are part of something greater than ourselves, which is what public health is looking at. It is looking at not just one person. Is this one person all right? What is affecting this one person's health and well-being? It's looking at all of that. Not only how is that one person, but do they then have positive, healthy relationships? Are they then in that relationship within a healthy community and within a healthy society? So it seems to be that, especially in some places, I read an article here recently from India, where they were saying that there is actually a conflict because a lot of times we're scrambling for funds when it comes to research and implementation between the clinical side of things, that individual level, and the other 3 levels, whether that be relationship, communities, or society. So the individual versus not individual, I will say that. But it does not have to be that way, because we can all work together in this holistic view, as Anne-Marie so clearly and wonderfully described here just a moment ago. And we cannot treat people like they live in a vacuum, because what they experience, what they're going through, does in fact affect others. So if you are a person with lived experience, you can see the impact that that has on the people around you and the impact it has on relationships going forward into the future. And sometimes that can be positive, sometimes that can be negative. If you are a person who has experienced the loss of someone, again, that is something that impacts you. It impacts your relationships. It impacts on how you interact with others and what you expect out of relationships going forward in the future. So all in all, that's just to state we don't have to be in competition. There is no, it's clinical, not clinical. It's 2 siloed groups. There's clinicians and then there's everyone else. And that it doesn't have to be that way. We all need to work together for a comprehensive suicide prevention effort. So moving forward into the public health approach. So the public health approach includes 4 steps, and these are just the same scientific methods that you have heard over and over through the years, probably since you first made a baking soda volcano in elementary school. So the concepts are, you define the problem. What is the problem? Well, we know what the problem is. People are unfortunately dying too soon. Monitor the problem. We've begun that. We have some good surveillance systems in place. We have some good data collection. Yes, things can always be improved, but we do have methods where there is research available, whether that be federally, whether that be specific organizations that have collected data, whether that be military specific data. I mean, the point is that we have defined the problem. We have started collecting the data. Next, identify risk and protective factors. We're doing that. So we're looking at the data. We're looking at the rates. We're looking at the counts. We've started identifying what factors are associated with. Now, I very carefully stated associated with, not predictive of. So, point being is that we've started this process. Are we completely finished with that? Of course not. We certainly aren't. But we've started that process. And as data improves, hopefully we can identify more. As we identify ways to look at big data, not getting into the algorithms and machine learning conversation, but just stating that, as time has passed, how we analyze data, what we look at, the types of data we can analyze are very different now from 10, 15, 20 years ago. So the point being is that there will always be changes, hopefully improvements in that process. So then this is where we are. And some people will disagree with me on this, but this is where I believe we are now. Step 3, develop and test prevention strategies. Okay, so what do? You do evidence-based planning. You look at the existing literature. You talk to people through focus groups. You do community needs assessments and community surveys. You have stakeholder interviews. And again, as Anne-Marie just stated, you have interviews not just with researchers, not just with politicians, not just with loss survivors even, but also people with lived experience. You absolutely must have stakeholder interviews where people with experience are at the table and part of the conversation. So once you have that information, then what do? You develop your program, you develop your intervention, you develop something. So in the past, if we had an infectious disease, maybe we developed a vaccine. Well, there's no vaccine. And again, some people may argue that, oh, there could be, a bacterial or a viral, et cetera, cause. But the point is that we don't have, dare I say, a magic bullet to fix suicide. So because of that, we have to say we are here at this point. We have some information. We have identified some risk and protective factors, although we know there will be more. And we have started this evidence-based planning process. We have some interventions that have been implemented. And that comes into step 3 of that third actual step, I guess C, you would say, as rigorous evaluation. Once it is implemented, we have to rigorously evaluate it and make sure, is it in fact effective? Not just we think it's effective, so let's keep doing it, but is it in fact effective? Is it not harmful? How can we duplicate them if it is effective so that we can go to step 4, which is assure widespread adoption? How do you do that? Training, networking, technical assistance, further evaluation. And I'm going to add one on here. Sorry, powers that be. I say capacity building and mentoring, because if you have experience in helping others build and develop that themselves, in addition to technical assistance, training and networking, that's very valuable. Lessons learned. Don't recreate the wheel. So I've added that capacity building and mentoring.
That's fine with me.
So that said, I firmly believe that we are somewhere between steps 3 and 4, the develop and test prevention strategies and assure widespread adoption. So what we're doing is we have found some things that work. And so we are trying to spread those. An example, and I promise this, I was not asked to do this by my employer, but for example, in the CDC Preventing Suicide Technical Package, there are evidence-based strategies in there so that people that are trying to develop something don't have to develop something from scratch. They can look at evidence-based strategies to build from. So that being said, that's where I believe we are. So with that place, we still have so much to do. We have so much to grow. And I frequently see coming across the listserv or just in conversation or other places, okay, we've done enough research. Let's start implementing. Let's take that money and implement. And that's great. So I do say we need both, because we know our data is not absolutely perfect yet. We don't know all of the risk and protective strategies. We need more information, but at the same time, we have to start doing with what we have. And we have to start evaluating so that what we're doing, we know is effective, and that what we're sharing and what we're promoting is actually the best thing to promote. So that is the public health approach. And when you think about it, it's logical. It's what we all already do. You don't do the same things over and over knowing it's going to fail and just keep doing it. We all already do this. We figure out what's wrong, figure out what we need to know to do something about it, develop something to do about it. And then if it works, either keep doing it or tell other people, hey, this is what works. So this is what we're already doing in our everyday lives. But we have to start doing that across these silos. We have to start doing this in a comprehensive method. So get off my soapbox now about public health. So I actually came from, I started in individual and family development doing individual and family therapy. And then I moved into nursing. So I got out of the behavioral health field and went into physical health. And then I just was really, really disillusioned over the fact that there's never going to be enough providers, whether that be physical health, whether that be behavioral health, whether that be someone shaking a stick at you and saying a chant. The point is, we're never going to have enough people that are boots on the ground to help everyone that needs help. We have to start addressing this from a population base where we're addressing comprehensively using every person out there. And I love your conversation about the Army. We have to have an Army, and that Army is, I agree completely, not only your lived experience and your loss survivors, but every person out there, every community member, every person that has ever had a suicidal ideation ever in their lives, every person that hasn't, every single person on this planet is part of that Army. And that's what it will take to have a comprehensive approach to suicide prevention. Not one person with another person. And please believe me, I absolutely believe clinicians are so valuable, and I wish we had a million times more than we do, but we know that we don't. So we have to start addressing this with everyone, by everyone, for everyone. So that being said, I decided, I've been a part of AAS for a long time, and what I realized is that it was very clinically focused, being that it was started and promoted by clinicians for a number of years. That is completely understandable. But if we want to start looking at this comprehensive, holistic view of suicide prevention, we need to get everyone to the table. And the way we do that is we have a home for people that are non-clinicians, so that they can get together and they can collaborate and they can encourage, mentor, do their best work, and promote that across the field and throughout the world to prevent suicide. So I actually waited a couple of years and waited to see if anyone else was going to raise their hand and take this role on, and no one did. So now that I'm at a place that I can do that with my life, I raised my hand and I said, I want to do this. We need this. And as I've told many, many people, am I the absolute best person in the world to run a committee? Never said I was, but someone has to do it, and we need to bring people to the table. So we're going to do that. And that's what we'll do. Okay,
I'm going to pause you there. No, that's, I can tell you that on the feed, I'm listening and seeing some of the tweets that are coming up, and a number of people are saying how grateful they are. Well, not grateful, they're not you, that's my word. That how nice to see a public health discussion going on here. And I think that, and I really do, I do believe that that is so important. So I was at the table on Friday noontime with Congressman Joseph Kennedy III, and around the table. There were 15 of us, and the reason that he was asked to sit with us was that in one particular city of the county that I serve, as that we talked about the very things that we threw at him, the very things that you were saying. There are not enough, we don't have enough clinicians, we don't have enough adolescent and teen clinicians, caseworkers, anyone to work with kids, period. We were talking about the fact that that even the salaries for people professionally trying to work with suicide and behavioral health is so low and so difficult, and suggested that maybe one of the solutions is to offer student debt loan relief if they're going to work someplace for 5 years. And I kept thinking of the AmeriCorps type thing, you know, that whole process, and the Peace Corps of, hey, listen, if you'll give us a couple of years, you know, we'll help you out when you get back there. And see, I see that as a public health approach, because it's saying we need people to fill in these spots. So what incentive can we give them to bring everybody together? And I'm very grateful. And it's funny because the last thing he said as he turned and looked over at the side of the table that had the suicide people on it, how do we get rid of the stigma? And I wanted to blur it out, put it under public health, because people will go. If you ask anybody, Melissa, I talked to so many parents who have kids who have ended up in the emergency departments, who have self-injured, have expressed that they're not feeling okay, and the parents are so reluctant to even mention that they're getting their kids help, because they feel they're going to be judged as bad parents. And that is, I have a new hashtag. It's the letter PDJ. Prejudice, discrimination, and judgment. Hashtag PDJ. Prejudice, discrimination, and judgment. And that's what's holding people back from getting the care that they need, or even being comfortable to reach out for help. And that wouldn't happen under a public health blanket. Now, one of the links that I sent out to people just today, it was for those of you who went to the blog, the pre-chat blog, to see what we were going to be talking about tonight. I linked in an SPSM chat from November 8th, 2015. And the guest was Jerry Reed. And at the time, he was the executive director for sprc.org. And most of everybody who works in the field knows about that incredible resource. And he was preaching the same story. He was talking about that public health and mental health have to become sisters. They have to blend and almost eliminate blankets and worry about that, and just bring this, and that it has to be a community response to what we're doing here. So I was on the call with you on Wednesday night when you had your first pre-meeting phone call with who might be on this new AAS. And so for those listening, I shouldn't speak in acronyms. I'm sorry. The American Association of Suicidology has really stepped up to the plate just in the last 12 months. In particular, there might have been a whole lot of work behind the scenes, but it's only been showing up in the last 12 months in particular. Have all kinds of new committees for AAS members to get involved with. And if you are not an AAS member, back channel me and I'll let you know how you can do that. And if you are an AAS member and you are not involved in one of these committees, I'm going to have to bite my tongue. It would be nice if you'd consider it. So we have this new public health committee with Melissa. We have a new committee that I chair for impacted family. And we've already put up a sample toolkit. Our committee has our goals and objectives pretty well set for 2019. There is, for those of you, I want to say it's 2 weeks now, Lisa Morgan was on. What an eye-opener on autism and suicide. I just kept shaking my head. I read her book and I done the research and I was just dumbfounded. I really was. And we had a conversation about social justice, and there is a diversity committee. So there are some action steps being taken, and I'm not sure how that's all going to play out over the next 3 to 5 years. But Melissa, why don't you talk to people about, you had this nice list of, and I published a link to it in one of the tweets today, So you had some points that you wanted to make, but equally important, you got some more feedback from the people who came to the table. And I just want to take a quick, I don't know if, I'm sure Tracy can hear me. I don't see any questions, Trace. Are there any questions before we step forward? Is she going to be able to come back on? All right, if there are, Trace, why don't you throw it up into the feed, and I'll see it as it goes in. So Melissa, let's.
Anne-Marie, no, there isn't any. I haven't seen any.
Okay.
Just like small comments here and there, like you mentioned.
Okay.
But nothing. No questions.
No big questions coming up.
No,
okay.
No questions coming up.
All right. Thanks, hon. All right. So Melissa, the floor is back to you. Let's talk about what you proposed for the committee. And then unless anything comes up that I need to interrupt, roll right into the Wednesday night phone call. Not that I assume you got all the notes done, because I wouldn't have gotten them done yet either, but the floor is yours again.
All right, great. So feeling as passionately as I do about both preventing suicide and other forms of violence and public health, and I approached AAS after being a member for several years and being engaged longer than that, and said there has to be a public health committee. So I didn't just write something up by myself. I started communicating with people and said, if there were a public health component of AAS, what would you like it to be? What do you feel that is missing for those of us that are not clinicians? What is missing that you really feel like you need? And so I got a lot of information together. And again, that's me following the public health approach. That's my planning stage. So I wrote up a whole bunch of notes, and I compiled it into what I put into my proposal. And because I believe in you should always be transparent when it comes to developing a committee for others, so that we can all benefit as much as possible. I posted it. I posted it to the listserv, and I posted it to Twitter and said, what do you think? If there was such a thing, would you be interested? And the results, the back channel responses that I got, yes, there were a few people that responded publicly, but there was a lot of response between Twitter and the listserv, and I didn't even send it to the places, because at that point I had over 50 people that were saying, I want to be a part of this committee. I am a member and I want to be part of the committee. What was really interesting to me is that I had another almost 50 people that responded and said, I am not a member of AAS and I would like to be a part of this committee. I would consider becoming a member if there was a committee like this, because I just feel like there's not a place for me there. There's, it's just too clinically focused.
I need to
say it's too clinically focused. The point being is that people have felt that way, so they wanted a home. And so I use that term now a lot, a home for people that are not clinical, which is why I say you do not have to be a public health professional. You can be a clinician. It's not an us versus them. It's not siloed at all. It's just saying that we want everyone to feel welcome, no matter what field you work in.
So I'd like you to pause just for a minute.
Yep.
And I want you to say, David Klonsky, you are welcome here, because he's on the chat. Let him know he's welcome. David, we love clinicians. We do, really.
All clinicians, David Conti and all clinicians, anyone is welcome in this new committee. As a matter of fact, I do strongly encourage you to join and bring your opinion to the table and bring your viewpoints and your experience to the table. Because again, it's not about, we don't need an individual approach. We absolutely must have an individual approach, but it also has to be framed within the other levels of the socio-ecological model. We have to look at the relationships, the community, and the society as well. So we're all needed as part of this. So please feel welcome and join. And that's why I actually struggled with the name, because I wanted to make it very clear that it wasn't not clinical. It was for everyone. So again, as you said in your conversation on Friday, it's public health. It's everything. It's everybody. It is about what promotes health and well-being. And to steal from the WHO definition, it's not just the absence of disease. It's not just the absence of mental illness. It's not just the absence of physical health disease. So it's all of us. So that being said, I finally said, I'm just going to call it the Public Health Committee because that's what it is. It's about public health and well-being. And so I put that on the proposal. And part of what I proposed to AAS was use this as a platform to recruit and engage people that are engaged across the health spectrum. Anyone who is interested in the health, happiness, and well-being of others can be a valuable contributor in this space. So you don't have to be a medical professional. You do not have to be a mental behavioral health professional, but you certainly can be, and that's very valuable. So that also gives researchers a place to meet and have communication about ideas and collaborations going forward that crosses those silos that have been present for so long. We can talk about, what does the data say? We see this sometimes on the listserv, but having been a lurker for a long time myself, I know that there's a lot more discussion that goes on back channel than in the actual listserv. So again, part of public health is looking at epidemiology, looking at patterns, looking at data, trying to identify, what do we know, what do we not know, what can we trust out of what we know? What if things are conflicting? What if research says both ways? So it's a place to have those conversations, again, across silos. So I put this out there and got a lot of response back to it. I was very, very encouraged. And AAS generously approved the committee. And so at this point, I'm trying to get all of these ideas tied up together so that we can have our first official call. I will speak briefly about the planning call that we did. So I don't want to read off of the proposal since I believe you put it on the blog, but I hit a couple of the high points there.
But don't assume everybody's seen it.
Oh, that's true. Okay. So what I proposed was that this committee should be tied to specific actions, not just, oh, let's have a committee and let's all talk, which is valuable, but let's actually do things with that. It's that translation of action and of data into action. So we need to do that. So I mentioned the recruiting everyone in any profession into the world of suicidology, also providing a knowledge base for public health research, addressing population and community approaches to suicide prevention, engaging researchers in epidemiology of suicide, development and dissemination of population-level risk-based strategies, to evaluate current efforts for suicide prevention to inform and direct future decision-making, promotion of comprehensive suicide prevention through collaboration, and providing networking opportunities both at the conference and otherwise, and assisting in formulating responses to population-level events and policies such as natural disasters, federal or state or even community-level policies, regulations, and that goes right into what we discussed in the planning call. So this was what I came up with the pre-discussions I had before the proposal. There were some wonderful discussion on the planning call. Quite a few of the interests that were mentioned in the call were they were very specific, but within those broad categories I just mentioned. Yeah. So some ideas that were not already included are looking at global analysis, because there is global public health. We tend to speak just about the US, but we can learn a lot from other countries. Why are the rates in some countries decreasing, but increasing here in the United States? What can we learn? And also policy analysis. So not just laws, but also policies within hospital systems, within school systems. What's effective? As you stated earlier, There's a knee-jerk type of reaction after a suicide, and it's a, oh my gosh, what are we going to do? What are we going to do? And that's not necessarily evidence-informed or evidence-based. So helping to respond to those type of events and providing materials, which I know there's a lot of good resources out there, but people may not know they exist. And then showing how the public health approach has worked for other issues. It has worked for other issues. You can look at food safety. You can look at infectious disease and immunizations, cancer screening, heart disease, stroke. The list goes on and on and on. So I keep hearing, what would happen if we treated suicide the same way we treated drowning, or the same way we treated cancer, or et cetera, et cetera. And that also goes into the stigma, because public health is looking at how to promote wellness, not just respond to a condition, but to promote wellness and do primary prevention to prevent it ever happening. It makes sense, and that helps to overcome some of those stigma and discrimination barriers. And then one of my favorite phrases, translating evidence into action, not just getting stuck, so to speak, in the gathering data, analyzing data, reporting that, but what do we do with that? And how do we evaluate programs and share what we've learned so that we're doing what is most effective? So in a nutshell, that's what I've got so far. I'm putting it all together, and I'm happy to go forward and always open to hearing more thoughts, suggestions, comments. And we will be translating this into action. Yep. And moving forward with our first official meeting as soon as I no longer have the plague.
Whatever it is. And again, it's just, I just believe this is such an important conversation, and I can't encourage people more to seriously take a look at that SPSM chat video from 4 years ago. It's astounding to see the similarities between what your hopes are for the committee and some of the things that Jerry Reed kept bringing up about how we really need to move forward. I mean, one of the comments he made is we get stuck on evidence-based, the best practices registry. Oh, well, let's pick one out of there. He said, but that's a one and done. And this has to be a continuum of care that moves forward. And that continuum of care is my phrasing. He had phrased it a different way. And it brings me back to, so on Monday night, keeping an eye on the clock, on Monday night, Tracy and I had the honor of co-facilitating with another one of our coalition members a roundtable that we call the Re-Energize and Reconnect. And it's a wellness check workshop for attempt survivors and loss survivors and impacted family members who are further along the healing path. And we had a reporter there. So that's what was so unusual about it. So the deck was stacked. We did not have anybody in that room that wasn't seasoned enough to be able to not be concerned about media coverage. However, we had one loss survivor come in that most of us knew, and she's less than a year away from her loss. And we were planning on stepping aside and setting up a small little room just for grief support, because that's what she had come from. And she said, no, I'd like to sit in on this and learn. And again, it was everything that got shared around that table, because it all focused on a wellness exercise of dreams matter. Because whether you're an attempt survivor or a loss survivor, and this ties right into the whole public health approach, because that's how we wrote the curriculum. So if you're an attempt survivor, a loss survivor, or like me, an impacted family member, we have all deferred dreams in some way or another as a direct result of being touched by suicide, some aspect of suicide. And many people never talk about that because, as much as we talk about so much from the very day I stepped into suicide, away after being with domestic violence and substance abuse, the Department of Public Health reached out and said, hey, would you be willing to come over and do some work with us? And I said, sure. And from the very beginning, it was all about prevention. I was part of the Garrett Lee Smith State and Tribal Grant. And so it was all about prevention, prevention, prevention. And I kept picking my head up and saying, what are we doing about the quality of life? How about we're talking about the quality of life before someone ends up in that crisis? And equally important, if they do end up in the crisis, how do we not pay much more attention to expanding that quality of life? Because to me, Melissa, that's how I define the public health model, if you will. I've identified the problem. I know what it is. We know what that is up front, okay? People are dying by suicide. People are feeling so uncomfortable. They're miserable. So we identify it, we do something with it, we move up those 4 steps that the public health model always puts out there. But the bottom line is, to me, my perspective, which can be twisted a little times, is that we have never in the field put enough attention on either end of that about the quality of life. So people can struggle, but don't want to end up in a position where they might die. And then the traumatic impact that has on everybody. So that's what our Re-Energize and Reconnect little workshop was all about. And again, this is now a part of AAS through the impacted families. So I'm excited that I think we have 2 committees that we can play with anybody. Between the impacted family is going to be, I can sit down at every table and say, really? Tell me a little bit more about yourself. Give me 5 minutes. And I bet I can connect you to being an impacted family member. And everybody, it should be at least, hopefully would look at all their perspective. Let's take a look at this public health conversation. So I am so thrilled that we've been able to have this and get it out there. And the good news is that it's interesting, and I'm not sure if it's the time of night, the day of the week, or whatever, but we will see probably far more. The stats are showing, speaking of data, the stats are showing that more people will watch this after it's done and watch the feed after it's done before they see it here. And I just got distracted because Tracy just plugged in. 2 public health messages helped a ton of, the downstream drunk driving. That's right. Designated driver and friends don't let friends drive. Oh my God. I can go down a litany of the public health. Adolescents recognize the signs of a stroke. They can go to Maybe or Nana and they know what's going on. I'm also a firm believer that children learn what they live. I mean, I that sounds so old school, but when people say to someone, how did these kids come in and start talking about suicide? And I went, has it occurred to you that they may have heard inadvertently a parent or an adult say something really silly in the heat of an argument? And I said, and because sometimes we adults will say stupid things when we're angry. And I used the perfect example. I can tell you a number of years ago, I was at a social event, family event, and a little 5-year-old dropped about 4 F-bombs in front of everybody. Everybody stopped, everybody just didn't move, didn't know what to say. And mom says, where did you learn that? And I just turned and looked at her and I said, can I go get a mirror? Here, let me hold it up. And I said, she didn't learn that on television. I believe children learn what they live. And if we live a public health model and we live that openness like we do about cancer, I train police every Wednesday morning. And I say to them, in a heartbeat, if one of you said you needed to go to biopsy, you'd all be right around him. I said, why can't you do that if someone says, you know what, I'm not doing okay? And of course, no communication coming back on that. But we're up to 9:54. So I'm going to turn it over to you and Tracy's back. I'm going to turn it over to you to take a deep breath and what's your takeaway? What's your final thought here?
So to me, I've been talking a lot about the technical aspects, the steps of the public health approach. But the thing to remember is that the entire purpose of public health is this upstream approach. It's all levels of prevention. Primary prevention, preventing the issue from ever happening. Secondary prevention, addressing it when it's there, when it's right there with you. And then tertiary prevention, dealing with it for the rest of your life. I mean, think of that with postvention. So, just realizing that it's across this entire spectrum. And the reason I am so passionate about public health is the simple statement of Public health meets people where they are. We don't ask them to come to us, we go to them. It's the entire concept behind what so many programs are doing. It's gatekeeper training. It's research. It's everything. It's just going up to someone and saying, hey, are you okay? Even without any formal training, that's public health. And that's the thing to remember. We can put specific strategies together that we know are evidence-based, but when it comes right down to it, everyone is public health and everyone can do something good for someone else.
Thank you. Trace? And any final thoughts?
Well, I really agree with everything because if we did take a public health message to it, and thought of it like as if someone had a bad heart or if someone had cancer, like we said before, like I didn't realize the discrimination until I had cancer myself. Mm-hmm. So then I fully understood because everybody was coming out of the woodwork to help me, want to take me places, take me to treatment, want to, clean my house, everything, and it's just like, but where were they when I was suicidal and I was depressed and I couldn't get out of bed or I couldn't get in the shower? Where were some of those people? You know what I mean? That's yep. where I think it ought to be.
Yep. So. Absolutely. So in wrapping up, Melissa, thank you. In spite of not feeling well all week, for being a champion to say, yeah, sure, I can. And that's exactly what she said, everybody. I said, hey, listen, you want to come on the chat Sunday? And she said, sure. Little did I know that she was sitting there trying not to cough all over us and not feel well. And I'm continuing to see.
You can't catch it.
Yeah, I know. That's the advantage of being from the distance, right? And I want to be clear on two things because I've seen a couple of comments on the feed. It is sometimes difficult to have the conversation that we're having. And it's not intended to come across anti-clinical. It's not. And I know that's how Melissa and I both feel. We've talked about it. I know Tracy and I go through the same thing. In some of the, when we're speaking with people and we're talking to kids and we're talking to adults, it isn't that at all. It's a matter of a level playing field. That clinical background has so much to offer to both mental health and public health communities, but likewise, so do the feet on the street peeps, who have it. And I think we need to maybe make a little more progress in that being very accepting. Tracy and Tom Cruise shared a workshop at AAS last year down in Washington, and it's about the positions that they both hold as certified peer specialists, one civilian, one military. And at that time, and here's how progress can happen, and at that time, Tracy said that she sometimes felt like the token person. She works on a crisis response unit, and she sometimes felt like the token certified peer specialist. But Trace, didn't you just say 2 weeks ago that has changed, correct?
Yeah, because now they look to me to want to help the clients. They recognize my value and the importance, the important role that I play when I do speak to them, because on a peer-to-peer level, they'll listen to me first before they'll listen to the doctor or the psychologist or the clinicians or even just a nurse.
Meaning your clients.
Yes, my clients.
Yeah.
Yes. You know what I mean? Because it's like, they're hearing it firsthand by experience.
Lived experience, right?
Yes.
Thank you. So everyone, it's just about that time. And once again, it's like, really? That was an hour? That was a whole hour. And you know what, Melissa? We're doing this season to the end of June. So let's consider maybe getting towards the end of June, if we can, maybe bringing on you and a couple of your members of your committee and see where, it's not that, I mean, that's not a lot of time to gel and do things, but I'm planning on bringing back just about everybody who's been on in the first 2 months, bring them back for a follow-up, a part 2, a redux and a reboot, and say, well, since our last conversation, how have things gone? And what's changed? So we'll come back and revisit this. If you are interested in public health and suicide in particular, obviously, that's what we're talking about. That's what we're always talking about. Then Melissa has a new committee. The one requirement and the only requirement, you don't need degrees, you don't need anything else, you don't need certification. The only requirement to be part of any of the AAS committees is to be an AA member. And please back channel either one of us as to if you are interested and you're not an AAS member, and then we can talk about how we can work that out. So we have an Impacted Families and Friends Committee that you can be part of. We have diversity. We have autism and suicide. Wow, what an incredible subject that is. We have IT stuff that gets really weird, but it's exciting to listen to. I feel like I'm talking Star Wars and Star Trek at the same time. But anyway, so it's and I don't know. I don't know what's going to happen with the Public Health Committee, but I can tell you with our crew from Missouri and across the country on Impacted Family, we really laugh a lot and we do have fun. But it is time to sign off. Thank you, everybody who was on tonight on the chat. I look forward to reading. The Wakelet will be curated. And did you just lift something off your lap? Was that a cat?
It was a kitty. I saw it.
All I saw was something just go by my face, and I went, what was that? So anyway, so there'll be a Wakelet curation, and this video is being recorded, and I'll have those links up to you in about an hour or an hour and a half. Don't stay up and wait for it; it'll be there in the morning, so that right, so you want to sit up and wait for it. All right. So good night, everyone. We will see you next week.
Thank you for being here.
Good night.
Bye.
Thank you for having me.